At the onset, sincere thanks to Professor Dhiman, Dr. Amit, and the whole team for giving me an opportunity to present this topic. Sorry for my voice, I'm just suffering from some viral fever. So to start the topic, refractory ascites, this is a picture that is taken from 1654 from a French museum. This shows a person with large tummy filled with fluid, and a pipe has been inserted to drain the fluid out. This is akin to large volume paracentesis that we still do for patient for management of refractory ascites. So more than 400 years, therapy more or less in many centers do still remain the same. So I'll discuss the topics under these headings. To start or give an overview, cirrhosis in layman terms for residents, it may just be akin to building a dam on river. So suppose there is a dam built on portal vein, there will be congestion to the tributaries of portal vein, that is mainly the splenic and SMV. And this will lead to splanchnic vasodilatation, and there would be loosening of gut, tight junctions of the gut, bacterial translocation, endotoxemia, and this would go into systemic circulation and cause systemic vasodilatation. So there will be cirrhosis with splanchnic and systemic vasodilatation, in effect decreasing the effective arterial blood volume. This defective arterial blood volume is decreased without overt loss of fluid, and this leads to decreased GFR, severe renal vasoconstriction, renal dysfunction, and ascites formation and the whole complication of ascites. So there is no overt loss, it's a third space loss, and basically it's due to decreased effective artery blood volume that is there in the circulation to counter it. So coming to refractory ascites or true diuretic resistant ascites, it happens in patients with advanced cirrhosis. They have maximal neurohormonal activation to counter the decreased effective arterial blood volume. They have decreased GFR, so the urine sodium is very low. Often it may be less than 30 or maybe less than 10. And we are giving maximum dose of diuretics. This is almost like squeezing an empty bottle and taking the last drop of diuretics out. The GFR is low, but increasing the dose of diuretics, so it may not help. And guidelines do suggest to stop diuretics if urine sodium is less than 30. It's akin to a pre-hepatorenal syndrome and has a poor overall prognosis. So refractory ascites can be defined as diuretic resistant, intractable, or recivident. Resistant is lack of response to treatment. Intractable is diuretic-induced complications. Majority of time, this is the more common variety that we see. Up to 80% to 85% can be diuretic intractable, and 10 to 20% may be diuretic resistant. Recivident is early recurrence of ascites. So resistant to what? Resistant is resistant to maximal tolerated dose of diuretics for a duration of at least 5 to 7 days with inadequate weight loss. Complications includes encephalopathy, AKI, dyselectrolytemia. So these are the important parameters to define diuretic resistance. Now coming to pathophysiology, to start with, the compensated cirrhosis has normal effective blood volume. But as the cirrhosis progresses, body tries to compensate. There is increased splanchnic arterial vasodilatation, systemic vasodilatation. The blood pressure may come down. Cirrhotics anyway do not have very high blood pressure because of splanchnic and systemic vasodilatation. There is increased degree of activation of renin-angiotensin-aldosterone system. So initially, this is effective arterial blood volume is in the zone to reduce or prevent ascites formation, or if ascites forms, can be mobilized. But with the progression of disease, the effective arterial blood volume becomes much less. There is more and more water retention and AKI development and decreased GFR. And here the ascites that develops becomes very refractory to treatment. So basically, it's a circulatory dysfunction leading to effective arterial hypovolemia in presence of maximum activation of vasoconstrictor system that leads to development of refractory ascites and all its complications. So the main players are increased portal pressure, gut congestion, bacterial translocation, splanchnic and systemic vasodilatation that leads to persistent reduction in effective arterial blood volume. Body tries to compensate, but there is an exhaustion of compensatory mechanism, and there is reduced cardiac output to overcome this. So this reduced GFR ultimately leads to ascites that is difficult to mobilize. Impact of HVPG studies have shown that HVPG more than 19, ascites becomes very difficult to mobilize. But this is mainly in the 20% of ascites that we are not able to mobilize in spite of high dose of diuretics. Otherwise, when you have complications, HVPG may not be very high in that, as we mentioned. So as the HVPG increases, the congestion increases, and there is further decrease in total blood flow and increased gut congestion endotoxemia. Coming to the renal impact, here the main issue is happening. The diuretics don't seem to act. There is diuretic resistance. And why is that due to? So there is decreased GFR because of severe renal vasoconstriction. This decreased GFR would lead to increased proximal reabsorption of sodium and chloride. So more solutes are absorbed. Then this would lead to increase of water absorption in the descending limb of loop of Henle. So less and less fluid is available to the distal part of collecting DCT and collecting tubule. Apart from that, this would lead to increased aldosterone secretion in the collecting duct because body perceives it as a hypovolemic state. ADH is released. You look at the black arrows there. So the black arrows on the normal and the black arrows on the right side are significantly less, showing that the amount of liquid available to the kidneys are significantly low in a hypovolemic state that body perceives it as. So there is increased fluid absorption, increased ADH secretion, significant water reabsorption. This leads to a small amount of highly concentrated urine that these patients pass instead of large volume large volume urine. So experiments have shown that plasma renin, norepinephrine, and ADH are high, but these are not only high in refractory ascites, they are elevated even in patients with ascites. So ascites per se is a hypovolemic state, and refractory ascites is an exaggerated form of hypovolemic state. Because of this, there is a diuretic resistance. Now, diuretic resistance can be pharmacokinetic, where we keep on increasing the dose of diuretic, but since the GFR is decreasing, the furosemide does not reach the tubules to act. And other is pharmacodynamic resistance. It is because of impaired diuretic secretion. The dose of furosemide is shifted down and towards the right. And this is predominantly because of impaired GFR. So the tubules do not have furosemide for interaction. If you imagine this, it is a cartoon to depict effective arterial blood volume. Now, the effective arterial blood volume can be of decrease in effective arterial blood volume can be of varying severity, as this cartoon shows. It's basically dependent on the amount of portal hypertension, albumin, systemic and splanchnic vasodilatation, and you have to fill the gap so that the GFR is maintained and there is furosemide available for tubules to act on. So this effective arterial blood volume gap has to be filled for refractory ascites or ascites to be mobilized. Treatment options are following. Long-term albumin in refractory ascites. This has been shown to be effective. 20 grams twice weekly for 24 months has shown to improve ascites and reduce the incidence of hepatorenal syndrome, reduce hepatic encephalopathy, reduce the incidence of SVP and non-SVP infection, and variceal bleeding. It has also shown to improve the probability of being free from hospitalization. So long-term albumin, emerging role in refractory ascites. Now, large volume paracentesis has been going on for long, and large volume paracentesis, especially we are doing for more than 5 liters, albumin has been the go-to drug. It has been found to be better than saline and other volume expanders. RCTs do support albumin in this, as albumin has shown to reduce the incidence of morbidity, mortality, and PICD in such cases. Studies from PGI Chandigarh have shown that albumin is equal to terlipressin and terlipressin is equal to NORAD in reducing the incidence of PICD. So it is not about albumin, terlipressin, or NORAD. It is about reducing the effective arterial blood volume gap. You can either increase by oncotic pressure or do by vasoconstriction or combination. Combination vasoconstriction with albumin should reduce the gap of effective arterial blood volume to help overcome this. TIPS has been shown to be effective and better survival than paracentesis compared. But the issue is hepatic encephalopathy. As hepatic encephalopathy, excuse me, hepatic encephalopathy's episodes were significantly higher in TIPS group. You can see the meta-analysis done on the same shows that hepatic encephalopathy rates were slightly higher, but these were the era of TIPS getting blocked also and non-PTFE stent. But with PTFE stents, the TIPS patency has improved, though the issue of hepatic encephalopathy does remain. The problem with the TIPS is if the patient is sicker, TIPS is difficult to do. CTP score more than 30, high MELD, TIPS becomes slightly difficult and more risky. The summary of multiple randomized control trials do favor TIPS over large volume paracentesis for patients who are not very sick. Now, if you look at this crux pathophysiology that we have, that is portal hypertension, splanchnic arterial vasodilatation, hypoalbuminemia, and systemic vasodilatation, they are basically reducing the GFR. So the fluid is not able to mobilize. Here, there is a role of vasoconstrictors coming in to improve the GFR, reduce the effective arterial blood volume gap. Now, one of the oral vasoconstrictors available is mirrodrine, that is an alpha-1 agonist. It increases both splanchnic and systemic vasoconstriction and has been shown to be non-inferior to albumin as far as LVP and PICD goes because it improves the renal perfusion and sodium excretion. Mirrodrine in refractory ascites has shown to improve renal dysfunction, improve the systemic circulation, reduce the renin-angiotensin-aldosterone system. Once you improve the GFR, then with diuretics, even if you add vaptins, they will mobilize fluid more because the collecting ducts are filled with fluid to get the fluid out. So combination of mirrodrine with tolvaptan with SMT was found to be better in a study from Videndra Singh from PGI Chandigarh. But still, one shoe doesn't fit all. As we saw in the previous picture, the amount of effective arterial blood volume can vary from person to person, and some people may have a very poor effective arterial blood volume. We have patients with ACL of refractory ascites with a SVR of 500, renal artery resistive index of 0.8, 0.9. So here you may require a low-dose combination strategy of adding 30% to counter splanchnic arterial vasodilatation, albumin to correct the hypoalbuminemia, and low-dose chloride to counter systemic vasodilatation. That is the GFR, add diuretics, get the RNR, renal artery resistive index low, and you should achieve a urinary sodium of more than 80 to mobilize difficult to treat ascites. In one of the studies from Gastroenterology department from our center, we had this response-guided infusion of albumin with vasoconstrictors to mobilize refractory ascites in ACLF with AKI. And it not only showed improved survival, but also had significant impact on gut permeability, cytokines, endotoxemia, and survival. On the right side, it showed that patients who could achieve urinary sodium of more than 80 within 2 to 4 days did much better. But patients who did not achieve urinary sodium of more than 80 at day 7, none of them survived. So that showed the amount of hemodynamic derangement that these patients have. Faster we correct the hemodynamics, better it is. Here is again the same study shows lactulose mannitol ratio that's showing the permeability and endotoxemia. We could show a linear correlation between permeability and endotoxemia because gut is congested, endotoxins would go up. Until you counter the congested guts and hemodynamics, it's difficult to overall have a balance on altered hemodynamics. Non-selective beta blockers have shown increased mortality in one of the studies with 175 patients of refractory ascites, and if you are having difficult to mobilize fluid, may stop it. Alpha pump has been used in the West. It's just a pump that sucks fluid from the peritoneum and pushes it into the bladder. But alpha pump significantly delays the time to first LVP. But alpha pump has its issue. You are doing a surgery in a decompensated patient that itself has high morbidity and mortality. So alpha pump made no impact on survival on patients with refractory ascites. Meta-analysis, systemic review and meta-analysis of alpha pump with 9 studies and 8 case series and 1 RCT did not favor alpha pump. It increased the incidence of AKI and SVP in patients with refractory ascites. EASL guidelines on refractory ascites suggest large volume paracentesis with 8 grams per liter of albumin for ascites removed. Diuretics should be discontinued if urine sodium is more than 13. If urine sodium do not achieve more than 30, although controversial, non-selective beta blockers should be used with caution. Last, if nothing works, transplantation is the go-to thing. Survival with transplantation for patients with refractory ascites is very good, up to almost 90% 1 year survival. So in a nutshell, it is not just a liver problem, but an effective hemodynamic problem where there is varying degree of decreased effective arterial blood volume that requires to be fulfilled. Difficult problem, have to assess the pathophysiology, and a guided treatment to uplift the effective arterial blood volume may help mobilize fluid and increase lifespan of our patients who don't afford transplant. Thank you.